All right. Kind of a quick introduction, quick overview of international health organizations. And a lot of it really started at the Almada conference. And we talked about primary health care for all. And that's the logo, healthcare for all by the year 2000 then. And that the World Health Organization and other, that's kind of the main leading international health agency came up with. So let's talk a little bit about what they do and that. So international health organizations are bureaucratic, right? They're what does it mean to be a bureaucracy? According to Max Weber, famous sociologist, one of our founding theorists, it's a type of administrative structure that has to do with rational legal authority. So Max Weber talked a lot about how power and domination occur in society, in cultures, and and it's enacted in lots of different ways. And he said, well, there's pretty much two ways that power or authority is given, and one is through the legal route, right? Like government authority, and that's different from. So it contrasts with traditional authority. That would be the second way, and or legitimacy, and that traditional authority is kind of like the Council of Elders or just sort of cultural tradition, what grandma says type of thing. So rational legal authority is important because it's a type of leadership that maintains itself due to the legitimacy of the structure that it's tied to. What does that mean? It means that the World Health Organization is the World Health Organization and has its power because the United Nations supports it, and a bunch of countries sign into the United Nations, right? So it's a sort of a superstructure of government. So they function as a bureaucracy. In primary health care, this comes from an anthropologist says this, George Foster. He says development assistance was established on the premise that the developed world possessed both the talent and the capital for helping backward countries to develop. Development know-how was spoken about as if it were like capital, a stock of goods capable of being transferred from its owners to the less privileged. So this is George Foster talking about the faults in the Almada Conference and the Declaration of Healthcare for All. Primary healthcare for all, I'm going to lower the video so you can see this. I don't know if I can. There, so now you can see it. Primary healthcare for all was about transferring technology. Like, okay, well, in the West, in the developed world, we have vaccines, we have medicines, we have doctors and nurses and blah, blah, blah. And we know about how to build latrines and purify water and sanitize water and things like that. So what we need to do is just go there, donate donate supplies, give resources, tell them how to do it, and blah, boom, done. Well, and in my other classes, we talk in depth about this. It's really not that simple, and it's a linear model. And that fits really well with bureaucracies, frankly. Let's be honest, bureaucracies like that type of unidirectional, linear model for making changes. So there are a few different types of agencies. One are multilateral organizations. That means multilateral means across different countries. So we have the World Health Organization, the United Nations Initiative for Children and Families. Ooh, I screwed up on that acronym. UNICEF. And then there are bilateral. Bilateral goes between two countries. So multilateral, the UN takes money and resources from lots of countries and redistributes it to lots of countries. Bilateral is one-to-one. That's the U.S. makes a deal with Guatemala, okay? And then there are private voluntary organizations, non-governmental organizations. So we have private secular organizations like the Rockefeller Foundation or the Ford Foundation. Rockefeller is one of the earliest influencers in international health. And then there's private religious organizations and medical missions. So they tend to be more interested in like interventions, like fixing a problem, fixing an immediate problem, than doing like preventative care. But that's not, I think I've seen the landscape changing a lot on that in the last decade. So I don't think that that's necessarily the case anymore. I think global health in general has been making a shift to much more comprehensive, preventative, like more broad-based interventions and programs. So a little bit more about bureaucracies and why this matters, because theories do matter. Theories, dictate how we think about the world, and they help us understand it. So sociocultural systems, meaning having social structures, having a culture to themselves, having language and discourse and terms and roles that people play in it, right? This is all of that comes when we say sociocultural system. And how do we see it? Well, we see it in money. Money is a big thing, right? They have, so budgets really dictate. That's where we show what has priority, what has preference, etc., what has value. But corporate memories tend to be really limited, right? You have this board of directors or something like that, and while they're there, gonna kind of follow their agenda, their priorities, but those don't. They're not necessarily. You might get a new CEO or something, or a new director, and have like a shift. So pretty limited memories in terms of the goals and mission can change quickly, but they're full of doctrines and ideologies. And we see this through things like mission statements or value statements, the types of programs they enact. There are professional and personality factors as well in terms of how people interact. They tend to set up things, bureaucracies tend to set up things as us, them, the professionals and the clients. And then you can do a lot of behavioral research on them and see the things like workshop syndrome, where you're just always, workshop syndrome is when you're always in workshop, right? We're always in meetings, and we're always talking about the next plan or the next initiative or what we're going to do. And perhaps, right? So what can happen in that syndrome? You're always just like focused on, okay, well, we better have a workshop. We need to have a workshop. Let's get together. It's kind of like having committee meeting. And instead of kind of pausing, letting things kind of happen organically, reflecting on what's happened, trying alternative paths. The point is sometimes we get addicted to the work routine, the work structure, instead of, and that can leave to the side things like reflection or formative evaluation. So in India, this is where the Almada conference was held. We want to look at the structure and services that they had for primary healthcare there, just a little bit, because this is where the Almada conference, the idea of primary healthcare for all came from. So the concept of primary healthcare this is from the 1978 Almada Declaration. It's the essential healthcare based on practical, scientifically sound, socially acceptable methods and technology, made universally accessible to individuals and families in the community through their full participation and at a cost that the community can afford, to maintain at every stage of its development in a spirit of self-reliance and self-determination. So this is like we talked about, right? I said, we read the Foster quote, and Foster said, this is very linear. It's very much like we have the science, and we can send it to other countries, and they can participate and pay what they can afford. So the idea of paying for medicine is really a very Western capitalist idea. The idea is that people don't value what they don't pay for. And in economics, for example, there's moral debates that go on about that. Is it true that people don't value what they don't pay for? And you can probably think anecdotally about that. If I said, if you had to work for years to buy yourself a new car, or slightly used car, are you going to take really good care of it because it took you like forever to save and work? And well, the logic is, yeah, right, that then you're going to take really good care of it. Versus what if I said, well, you have your kid, and they don't, in the US, our kids don't, it's not like in more traditional agrarian societies where your kids are labor and they have like that value of the work that they're going to do on the farm. Our kids are mooches, right? But you can't put a price on it, right? So there's moral limits to it. And you could think anecdotally, are there some things that how much you pay for it? Like if you have your really, really nice outfit that's name brand, or I don't know, like designer, do you take better care of that? Yeah, maybe you pay to have that dry cleaned, and your other clothes you just throw in the wash. So there's a little bit of logic to it, but it has limits, that way of thinking. And that's important in health, because people say, well, your health, wouldn't you pay anything for your health? But also, isn't that morally incorrect, because then that leaves the poor at a real disadvantage? So only the wealthy, right? So we have this moral dilemma. The primary areas of focus in primary health care: education, food and nutrition, water, basic sanitation, latrines, water supplies, etc. Maternal and child health, including family planning. Remember, well, we still have in some countries where family planning is a top agenda item, but 1978, and in India, growing population, neighbor to China, very rapidly growing population, family planning was a big thing. So that was one of their main impetus. Immunizations, prevention of locally endemic diseases, so that would be like malaria and malarial regions, things like that. Appropriate treatments of common diseases and injuries, TB maybe, right? And provision of essential drugs. So that was the model of primary health care. It doesn't sound right, it's not a bad model necessarily, but it evolves. Let all be free from disease, let all be healthy. That's where the healthcare for all came from. This is the Boer Committee report from 1946. If it were possible to evaluate the loss which this country annually suffers through the avoidable waste of valuable human material and the lowering of human efficiency through malnutrition and preventable morbidity, we feel that the result would be so startling that the whole country would be aroused and would not rest until a radical change had been brought about. This is from India. So here's the overview of the history real quick. So we have the Boer Committee puts forward kind of the concept of primary health care in the late 40s, mid 40s. Then we have the Kartar Singh, sorry I butchered that, committee in 1970s. We'll get this rural health scheme in the 70s. And this is what's going on in India. So like I said, the model really comes from India because they started using rural doctors, right? They started sending people out and saying, okay, you're going to be a rural health. This is the early days model of having people who would have the necessary training for what they were going to encounter, right? Like the common diseases, vaccinations, nutritional stuff, hygiene, sanitation stuff. And they would send them out into communities. We call them the barefoot doctors, right? And then in 1978, so we have this big conference in Almada, lots of global leaders, international leaders come, and we make the Almada Declaration, primary health care. So what does it look like now in India? This is in the past 10 years. So they've had universal health care coverage reform. So they've reduced the social disparities. They've changed the way they deliver services, sending so-called barefoot doctors out, right? Just trained rural healthcare providers who were trained in the necessary things that they needed, given the tools that they needed, and sent out to rural populations. And integrated health into all sectors through public policy. And they pursued collaborative models of policy change, so leadership reform, and increasing stakeholder participation. What does that mean? Who are stakeholders? Well, that's everything from the people who receive the services, everyday community members, all the way up through the top levels of government. And they do that usually through things like forming community advisory boards or something along those lines, having regional delegations, having so that there is a way for the voice of a rural village and their needs. There's a way for that to make its way up the ladder, up the chain of command, and be heard and be what's the word? But to be kind of like united with others. So if we have things going on in this village and over here, and different regions are all experiencing maybe the impacts of a drought or something, that they are able to be united in sending that message and getting the assistance that they need from the government allocations. So here's what their structure looks like. That's probably a better visual than my attempt at explaining it. So you have sub-centers that will be over certain villages and such, and then this is where people would get referred up to a primary health center and then maybe to a regional hospital or a district hospital if they needed it, right? So getting people moved up through that chain, what's really important there is to have seamless transitions. So to have proper communication, so that if you find somebody who has like advanced cancer or something, or a vision issue that is advancing quickly, they need to move quickly up this chain. There can't be gaps and like, oh, whoops, we lost their paperwork. A month later, oh yeah, come on in, right? It needs to move quick. And so that flow and the efficiency in the system is really important. So the services, education, nutrition, we already talked about this. I went over it in the earlier slide. Water, basic sanitation, maternal child health, family planning, a big part of that. The time talking to people about, in India in particular, this was a big part of it. Immunizations, controlling endemic diseases, things that are reoccurring in a population that persists there. Appropriate treatment of common diseases and injuries, provision of essential drugs. The octagon of primary health care. So 8 things. And there's another visual of it. If you're a visual learner, right? I am. So what are the challenges? Infrastructure. So you've got a growing population, in a place like India and most of the developing world. So how do you scale up? And also people in developing countries, we have that, remember we talked about urbanization. So if people are moving into urban areas, that's going to shift the balance of resources and the types of needs, health needs. A changing demographic profile, meaning you're having more elderly. People are aging, they're living longer, which is good, right? They're living longer, but you have different needs later in life. You can't work, you need help, right? And so that's important. Think about the aging population. The triple burden of diseases, which is the aging, the triple burden is the aging population, maternal child health, like the primary needs, and then the shift in, so when you're in a transition, you have infectious diseases, tropical diseases, things like TB, flus, influenzas that are still a problem. You need to treat those things. We need to get immunizations, good clean water supply, sanitation, etc. But then at the same time, we have shifts in the diet, which means that you have risks of hypertension, heart disease, everything that comes with diet and lifestyle, right? So diabetes, obesity, etc., type 2 diabetes. And then you have an aging population. So that's the triple burden of disease. And a lack of human power, people power, meaning labor. And they're talking about healthcare providers, right? We need to train healthcare providers and keep people happy, right? Like you can't just go out, and India was a big thing. How family planning was talked about, I think everywhere. So you need to relate well to people and have it be culturally appropriate. And then there needs to be research built into, it's not just the delivery of services. We should be constantly aware of doing research and improving. Robert Frost says this: The woods are lovely, dark and deep, but I have promises to keep and miles to go before I sleep. How does that relate to primary health care? Right. And so, and I teach another class that we really, really explore and go in depth about this. But the so just one final thought as we're thinking about the road ahead, and it is a long road. We've still got sort of amazing how long we can spend on a problem and not have the solutions yet. Sometimes gives me pause. But technology and money, those are the two things that we typically look at for sustainable development. This is a quote from a paper. Intermediate technology enables poor people in the South to develop and use skills and technologies which give them more control over their lives and which contribute to the sustainable development of their communities. What do they mean when they put capital S South? They don't mean the South of the US necessarily, right? They're talking about the global South. Because if you look south of the equator, we see mostly more of the more modern, industrialized, so-called developed countries in the north, and the south is where we see more of the poverty and things like that. So the idea of intermediate technology is like giving technologies that will allow communities to get to a certain point so that they then can learn those technologies, adapt them, maintain them, right? Like fix them when things break, etc. And that's part of the sustainable development model. So technology and money. We seem to think they're going to solve all of our problems.